M1 lesions are not uncommon in the clinical practice of a stroke neurologist. Making sense of M1 lesions. Welcome to another episode of Stroke Rounds.
It is about a 71-year-old male patient who came with a transient weakness of left upper limb associated with the dysarthria. At arrival in emergency room, patient was having left upper limb weakness with a grade 4 plus power.
So the patient was immediately taken up for an MRI and MR angio.
So the MRI, the ADC pictures are showing infarct in the right hemisphere in the MCA territory, and it's looking like a internal watershed infarct, probably internal watershed infarct, and the DWI image is showing and cortical infarct suggestive of embolic component in the MCA-ACA watershed area with the internal watershed infarct on the right side.
So, but it's all is in the territory of the middle cerebral artery. There is nothing seen in the anterior cerebral nor in the posterior cerebral, as well as there is nothing seen on the opposite side also. So when you see lesions like this, what could be the underlying vascular pathology?
The vascular pathology will be probable stenosis in the large vessels like right internal carotid artery or right MCA, because it is in the MCA territory. So ICA stenosis most probably it will be affected in the MCA territory rather than other parts like ACA or PCA. Now patient probably be having ICA or MCA stenosis right side. And this is the MR angiogram picture showing right internal carotid artery with right MCA distal almost severe narrowing with almost preserved
There is some disease of the distal MCA, M1 segment. So whether it is a thrombus with flow or whether it is a stenosis, it is difficult to say. So the next possibility we were discussing was whether it's a carotid stenosis. So the carotid artery is normal, perfectly normal. There is no stenosis, and we have to look into the arch of also. So this is a normal arch, type 1 arch. The left internal common carotid artery is arising from the arch. This is the brachiocephalic, subclavian artery, vertebral artery, left subclavian artery, vertebral artery. So this is the complete MR angio showing the M1 disease. This is the axial images. Which are the vessels? Now this is the basilar artery. This is the posterior cerebral artery. This is the left internal carotid artery.
left MCA, right MCA.
And here you can see the disease segment. So the patient was taken up for a diagnostic angiography. This is the common carotid angiogram. You can see the external carotid artery also here. So in this situation, always one should do a selective internal carotid artery angiogram to get excellent images, very good images. So this is the angiogram run showing the internal carotid artery, and this is the capillogram phase, and this is the venous phase. This is the still image showing the cervical carotid, petrous segment, cavernous segment, ophthalmic segment, distal internal carotid artery dividing into anterior cerebral artery, A1 segment. This is the A2 segment. You can see some disease here, intracanal atherosclerotic disease. There is some disease here, some disease here. Here the M1 is, proximal portion of the M1 is normal. Lenticular striate is seen very well. Before the bifurcation, you can see a very tight stenosis with a bend. This is almost like a trifurcation, 3 branches, but the distal vessels looks normal. So here you can make out very clearly that in an enlarged image, this is a very smooth atherosclerotic lesion with almost a 90% stenosis of the distal M1 before the bifurcation. So there is no thrombus, there is no features to suggest a dissection also. So what will you do in such a situation? Because we don't treat the angiogram, we treat the patient. So the patient on the cath lab itself, we assess the patient power became almost normal. So he had mild weakness only, which on examination in the cath lab was found to be perfectly normal. So we decided to wait for some time to see whether there's any fluctuation, which did not happen. So it was decided that why did the patient improve after the angiogram?
Probably we are while doing DSA, we will be using like heparin or nimodipine, which may help to clear out the clot,
clear out the
small
clot,
clot.
and it happens occasionally. So probably that was one reason, and the patient did not have any deficits at that time, so it was decided to manage conservatively. So manage the interventional option is to put a stent here, and it, being a curve, now when you put a stent here, this is not the proximal M1, this is a distal M1, so it will have to be go into this vessel, which is a very small vessel, like less than 2 millimeter vessel with a branch. So the chance of the stent getting occluded, especially in the bend, is very high. So it's better to manage medically. Medically means when you put them on dual antiplatelet medication. Maybe you can consider heparin because anticoagulation, because there was a cortical embolic infarct also. The third is keep the BP up. Hypertensive, the blood pressure management. Keep the BP at a higher level. If the patient is on an antihypertensive medication, stop that. Especially these hemodynamic events happen in the morning when they get up from bed or lying down for some time. And third is hemorheological management. If the hemoglobin is high, especially if it's a smoker, reduce the hemoglobin by venesection. So manage the patient medically. So this patient was observed in the hospital for 48 hours and then was discharged in a normal condition with an advice to report back if there is any recurrence of symptoms. Suppose if the patient has recurrence of symptoms, recurrent TIA with new infarcts in the MCA territory, then the patient can be considered for a stenting with a dedicated neurostent after explaining the risk of the procedure. But definitely, a medical management might be a better option in this particular situation. Please do share your comments, thoughts, opinions, and suggestions regarding this particular patient. See you next time with another episode of Stroke Rounds.